Hi, and welcome back to EPT's Documentation Orientation. My name is Mike Genko, and I'm one of the physicians with EPT, and to my right is Tom Wagner.
Yep, I'm here. It's kind of like frickin' frack doing documentation.
It's pretty scary.
Yep.
So, quick review from last time. We talked about the elements of the chart, specifically that the chart in the emergency department is an H&B combined with a discharge summary. Remember that we use a little bit of a different format in that we put our assessment and ED course first, and then our history and physical second.
Some would call that an APSO format.
An APSO format, absolutely. And that is to try and make it a little bit easier on our consultants and primary care physicians who are reading the chart after the fact. Obviously, the most important elements of the chart are history, physical, and medical decision making, and that comes from not only medical, legal, and communication standpoints, but also from a financial standpoint, in that those are the key elements that our coders use to determine how much to bill for each
Exactly.
encounter.
So the various payers have rules, and we're going to try to keep those rules as simple as possible. Remember, your chart tells a story. It should tell the story accurately. It should not include information that doesn't make sense.
Right.
And
today we're going to discuss the history section in some detail. We're going to take a deep dive into that. So what are the elements of the history? History obviously is made up of the chief complaint and then the HPI, past medical, social, surgical, and allergies, also family history. And those are all things that will pre-populate from entries in previous encounters within our systems. We use Epic, and Epic is designed to store those historical elements outside of the chart itself, and then when you start a new chart, those elements will be pre-populated right in.
so you can't always count on them being there, because sometimes they've been pre-populated. In fact, in many of our patients, they are. But occasionally you'll find patients where none of it is there. And so you shouldn't ignore that part of the chart. You should always look at it, because there are requirements for past family, social history, etc., which we will discuss further along in the series.
And the other thing I would caution you on is sometimes information gets entered there that's incorrect or inaccurate. And again, it's because somebody in an office or somebody in an outpatient setting may have mistakenly entered a past illness the patient has had, and then when you ask the patient about that, they'll actually say, no, I'm not. The big ones is when someone comes in and they've been marked as HIV positive, but they're not.
Or,
that's obviously a big issue.
Says they've had their appendix out, but they really haven't. And they've got abdominal pain, which is typically what's going to happen.
Exactly. So, and then review of systems is also a very important element of the history section, and we're going to talk about that here in a few moments.
Most of you, we'll talk about the review systems. So I guess you can talk about templates now, and we'll get back to ROS.
Yeah, so we wanted to take a moment just to talk about templates. And most systems now are using an EMR of some sort. We've mentioned before that we use Epic within our group. And Epic is great. It gives you a lot of power to create many different macros and many different templates. But there's lots of pitfalls associated with template use. And the biggest one that I see is when using templates generates charting inconsistencies within the chart. And you want to try to avoid those whenever popular. And as an example, this is actually from a chart that I had to review. It was a QA review that I did. And you look at this physical exam, and you may not be able to tell by looking at it, but it's clearly an exam that's been templated based on my experience. And if you look down in the cardiovascular section, and then you look at the vital signs here, you can see that that patient has a fairly unremarkable cardiovascular exam documented, but their heart rate's 128. And there's no mention of that in the cardiovascular exam, and it's something that obviously is important to most patients' evaluations. And this patient was an adult patient. It wasn't a pediatric patient that has a naturally fast heart rate. So just a brief example of how templates can be a little bit of a pitfall.
They can also cause you to over-document, which is a huge problem from a regulatory standpoint. So, for example, someone comes in for a suture removal or an ankle sprain, and you use your normal exam template that's got a detailed abdominal exam, a detailed cardiovascular exam, and anybody looking at that chart is going to say, why did they do all this work on this patient that's just there for an ankle sprain or a suture removal? Or do they always hit their normal exam no matter what they do? And are they, is this a fraudulent type of documentation
practice? Somebody is upcoding.
Exactly.
That would be the worry. So we talked a little bit in the last module about some of the financial implications and how exactly what we document is turned into revenue. And I just wanted to review that again because I think it's such an important point. The elements of the chart, the history, the physical, and the medical decision making are what determine our reimbursement. And within emergency medicine, 80%, usually 80 to 90% of any group's revenue comes from the evaluation and management codes. And those are the codes that are determined by your history, your physical.
You'll hear them
elements, and
referred to as level of service codes as well.
Level of service, yep, absolutely. 20% of your codes generally come from procedures. There are 5 evaluation and management codes. Level 1 is the most basic evaluation. Level 5 is the most in-depth evaluation. And then there are also critical care codes that we can cover in
we'll be talking about in
module.
future modules.
Right. And take-home point here is it's the amount of work that you do, not your diagnosis, that's going to drive your reimbursement. And again, that's a commonly held misconception.
Right. There are,
physicians.
Even if you can document a lot of work, but if the patient's there for a suture removal, you can only get so much reimbursement. So there are some caveats to that, but the system was theoretically designed to pay for work.
Right.
And not to pay for specific diagnosis.
So we're going to break down a little bit at the E&M level how many elements will drive what E&M level. And this is, I think, a nice breakdown of it.
Right. I mean, you can look at this and see that an E&M level 1 needs 1 to 3 elements in the HPI. You don't need a review of systems, and you don't need any past family or social history. And a very complex patient, level 5, needs 4 elements in the HPI or more, 10 or more review of systems, and 2 or 3 of past family or social history, as well as a complete physical exam. Now that you've seen this grid, I want you to forget it.
I kind of liked my grid.
I know, it's a great grid.
Spent a lot of time putting that together.
It's a cute grid, but you know what? It's too complicated, and I don't want people to have to worry about that.
So here's a key point for you. You only need 2 review systems and 1 past social or family history element to get to a level 4, an E&M level 4, and that's 1 step below the most complicated patient that we have. So think of charts as either being simple or complex.
Yeah, patient comes in for a simple complaint. They sprained their ankle, they hurt their arm, they cut their finger. Simple complaint, they need a simple chart.
If it's simple, try to get at least 2 review systems and 1 of the past surgical, social, family history, etc.
Exactly. And complex patients, on the other hand, chest pain evaluations, abdominal pain evaluations, altered mental status, a headache often. Mm-hmm. Those are the kinds of complex complaints, and it's not hard for you to figure out. These are patients when you come in, you start talking to them, and once you know that you're going to do a, quote, workup on them with several different testing modes, you know you've got a complex patient, and in that case, you need 10 or more review systems and 2 or more past family social history. If you do those 2 things, you will be right 99% of the time.
Yeah. Yeah, I was going to say 95, but I think 99 is probably more accurate.
I think it's almost 100%.
So hopefully that was helpful for you regarding the history section. We are going to take a look at the physical exam section next time.
Exactly.
And as always, if you guys have questions or comments or concerns or anything else, please contact Tom or myself.
Exactly. We'll see you then.